This is Alyssa Leone, and I will be presenting dysphagia and the role of the speech-language pathologist for CSD 331. So, to understand what a disordered swallow looks like, we must first understand what a normal one looks like. So, swallowing is also known as deglutition. This is a highly complex process that involves the transportation of a bolus, or food, from the mouth to the stomach. Groher and Crary describe swallowing as an integrated, interdependent group of complex feeding behaviors. They also say that healthy individuals simultaneously perform the sequential sensory and motor patterns of mastication, or chewing, and swallowing with little effort and conscious awareness. There are 4 phases that occur when an individual swallows. The first is the oral prep stage. This is a highly individualized phase in which the bolus is prepared through manipulation and the mechanical reduction of the food. The food's consistency and volume is prepared for a safe swallow. The oral phase is initiated when the bolus is propelled posteriorly toward the back of the mouth by sequential anterior-posterior tongue movements. These press the bolus against the hard and soft palate for initiation of a pharyngeal swallow. The pharyngeal stage is initiated when the bolus head passes any point between the anterior facial arches and the point where the tongue base crosses the lower rim of the mandible. Lastly, in the esophageal phase, the bolus is carried through the upper esophageal sphincter, the esophagus, and the lower esophageal sphincter, and enters the stomach via peristaltic waves. What is dysphagia? Dysphagia is disordered deglutition. Therefore, it is difficulty transporting solids or liquids from the oral cavity to the stomach. Groher and Crary define it as a disorder or difficulty with swallowing. Abnormal swallowing patterns may occur in any of the 4 stages of swallowing previously discussed. Difficulty swallowing may result from behavioral, sensory, and/or motor deficits, in some cases all 3. Dysphagia may occur in individuals of any age group with various degrees of severity. However, its greatest prevalence is in the geriatric population. There are 4 deviant events that can happen when swallowing. These are premature spillage, which occurs when the bolus falls over the base of the tongue into the hypopharynx before the pharyngeal swallow is triggered. Pharyngeal residue. This is when penetrated material remains on the supraglottic surface of the vocal folds. This can lead to aspiration if it is not successfully cleared. Laryngeal penetration is the occurrence of residue within the hypopharynx and is correlated with diminished movement, force, and pressure. Lastly, there is aspiration or airway invasion. This occurs when trace residue within the hypopharynx is not cleared after a single or a second swallow, and the material passes below the true vocal folds into the airway. There are 4 times when an individual can aspirate. These are before the swallow, during the swallow, at the height of the swallow, and after the swallow. Dysphagia may result from numerous etiologies secondary to damage to the central nervous system and/or the cranial nerves, and unilateral cortical and subcortical lesions due to stroke, traumatic brain injury, spinal cord injury, dementia, Parkinson's disease, multiple sclerosis, ALS or Lou Gehrig's disease, muscular dystrophy, developmental disabilities in the adult population like cerebral palsy, post-polio syndrome, and myasthenia gravis. Dysphagia may also occur from problems affecting the head and neck, including cancer in the oral cavity, pharynx, nasopharynx, or esophagus, chemoradiation from head and neck cancer treatment, trauma or surgery involving the head and neck, decayed or missing teeth, critical care that may have included oral intubation and/or tracheostomy, and certain medications. Dysphagia can also occur in patients who have certain metabolic disturbances, have infectious diseases such as sepsis or AIDS, in patients with a variety of pulmonary diseases such as COPD, in patients with GERD, in patients following cardiothoracic surgery and/or in decompensated elderly patients. There are various signs and symptoms associated with dysphagia. Signs are observed behaviors that people elicit during a physical examination, and symptoms are changes in bodily function that the patient notices and reports. Some signs and symptoms of dysphagia include drooling and poor oral management, food or liquid remaining in the oral cavity after the swallow, inability to maintain lip closure, leading to food or liquids leaking from the oral cavity, food or liquids leaking from the nasal cavity, complaints of a fullness in the neck or pain when swallowing, wet or gurgly sounding voice during or after eating or drinking, difficulty coordinating breathing and swallowing, recurrent aspiration pneumonia or respiratory infections or fever, extra effort or time needed to chew or swallow, changes in eating habits, specifically avoidance of certain foods or drinks, and weight loss or dehydration from not being able to eat enough. Other possible signs or symptoms of dysphagia include excessive secretions, food pocketing in the mouth, solids or liquids dripping out of the mouth, changes in respiration, nasal regurgitation, vomiting digested or undigested food, and struggling or posturing during the meal. Some complications of dysphagia include aspiration pneumonia and other respiratory conditions, choking or near-like choking, dehydration, weight loss, and malnutrition. There are certain clinical indicators which signal that a person may have dysphagia. 7 of the most reliable factors which indicate this are dysphonia or abnormal voice, dysarthria, which is a speech disorder caused by muscle weakness, abnormal gag reflex, abnormal volitional cough, coughing after the swallow, voice change after the swallow, and abnormal tongue movement. So, what is the role of the speech-language pathologist in all of this? It is ASHA's position that SLPs play a primary role in the evaluation and treatment of infants, children, and adults with swallowing and feeding disorders. In the document Knowledge and Skills Needed by SLPs Providing Services to Individuals with Swallowing and/or Feeding Disorders, there are 13 roles outlined, which SLPs are required to do when assessing and treating these patients. They are as follows. Role 1. Identification of individuals at risk for swallowing and/or feeding disorders. 2. Conduct a clinical examination of the upper aerodigestive tract. 3. Conduct instrumental examinations. 4. Determination of an individual's management decisions regarding methods of oral intake, risk precautions, and candidacy for intervention. 5. Provide treatment for individuals with swallowing and feeding disorders. 6. Additional knowledge and skills in assessment and management of swallowing and feeding problems in infants and young children. Role 7. Provide education, counseling, and training to an individual with a swallowing or feeding disorder, to family, significant others, the dysphagia team, health and education professionals. 8. Manage and/or participate in swallowing and/or feeding team. 9. Maintain quality control and risk management programs. 10. Provide discharge and dismissal planning and follow-up care. 11. Teach and supervise persons, clinical fellows, supportive personnel, and students in training. 12. Provide public education and advocacy for serving individuals with swallowing and/or feeding disorders. And lastly, Role 13, conduct research. Clinical assessments. The ASHA scope of practice for speech-language pathology states that the practice of SLPs includes providing services for swallowing or dysphagia and feeding problems. Clinical assessments of swallowing conducted by SLPs are both non-instrumental and instrumental in nature. The clinical bedside exam is a crucial non-instrumental assessment used by SLPs when evaluating patients who may have dysphagia. The main components are the reason for referral, so why is the patient here and what is their complaint, the patient's medical history and medications they take, their mental status or behaviors, the patient's posture, their dentition, their oral motor sensory functioning, the patient's vocal quality, and their respiration. What is the patient's pre-oral or pre-feeding status? Are they a candidate for food or are they NPO? If they are determined a candidate for food, then observation of the oral and pharyngeal phases of swallowing will follow. Then finally, diagnosis. It is important to note that SLPs only diagnose functional swallowing disorders. Then, recommendations and referrals will follow. Unlike non-instrumental assessments, instrumental assessments allow us to assess the physiology of the structures involved in swallowing. This can be especially helpful when there are inconsistent signs in the findings of the non-instrumental exam given. In clinical settings, SLPs typically use one of the two types of instrumental evaluations below. These are the VFSS and the FEES. VFSS, or the Video Fluorographic Swallowing Study, also known as the Modified Barium Swallowing Examination, is often considered the instrument of choice by the majority of practicing swallowing clinicians because it permits the visualization of bolus flow in relation to structural movement throughout the upper aerodigestive tract in real time. FEES, the Fiber Optic Endoscopic Examination of Swallowing, was created to provide information about the pharyngeal stage of swallowing in patients who cannot be adequately examined with video fluoroscopy. However, it is important to note that unlike assessment via the VFSS, FEES does not permit visualization of either the oral or the esophageal phase of swallowing. The goal of most treatment plans is to ensure that the patient can consume enough food and liquid to remain nourished and hydrated, and that the consumption of these materials does not pose a threat to airway safety, resulting in aspiration pneumonia. The selection of any treatment for the patient with dysphagia should be based on the best available evidence from the published literature, the patient's wishes, and the clinician's experience with similar problems. Treatment of dysphagia may include rehabilitative approaches, such as restoration of normal swallow function, or compensatory approaches like modifications to the diet consistency and patient behavior, or even some combination of these two. Treatment varies depending on the cause, symptoms, and type of swallowing problem present. The types of treatment that can be used for patients with dysphagia are listed below. These include biofeedback, which incorporates the patient's ability to sense changes like visual information from instrumental assessments to aid in swallowing treatment. Diet modifications, such as changing the texture, viscosity, temperature, or taste of the food they are eating. Electrical stimulation to strengthen the muscles that move the larynx up and forward during swallowing function. Maneuvers which change the timing or strength of particular movements of swallowing, such as the effortful swallow, the Mendelssohn maneuver, the supraglottic swallow, and the supraglottic swallow. Oral motor therapy exercises like stimulation to oral structures and the muscles involved in swallowing, including laryngeal elevation, Masako maneuver or tongue hold, the shaker exercise or head lifting exercises, and lingual isometric exercises. Pacing and feeding strategies including cueing for appropriate rate of eating and changes in bolus size. Postural or positioning techniques to redirect the movement of the bolus, such as the chin down posture, the chin up posture, the head rotation, and the head tilt. Prosthetics and appliances that can be used to normalize pressures and movements by compensation and physical support for patients with structural deficits or damage. Sensory stimulation, such as tactile stimulation applied to the oral structures, or temperature changes, such as using cold laryngeal mirrors. And finally, medical management of swallowing disorders, in which there are multiple options. These include pharmacologic options, surgical options, and behavioral treatment options. Here is a list of all the sources that I used for this presentation. Thank you for watching.